Muy buenas tardes a todos. Sean bienvenidos a un webinar más por parte de Integra Cancer Institute. Agradecemos a todos su presencia. Hoy tenemos un tema muy importante, cáncer de páncreas, su tratamiento y su diagnóstico y su tratamiento. Y para eso tenemos hoy un panel de lujo para ustedes, con la participación de 3 médicos internacionales que trabajan en la Mayo Clinic de Jacksonville, Florida. Voy a dejar las presentaciones más formales por parte del doctor Frank Lucas. El doctor Frank Lucas es guatemalteco, compañero y gran amigo mío. Estudiamos juntos en la Universidad Francisco Marroquín y posteriormente él hizo sus estudios en Estados Unidos, les contará. El doctor Brahmapat, también compañero de él en la división de gastroenterología endoscópica, y el doctor John Stauffer, que es cirujano hepatobiliar. Y vamos a estar hablando, como les digo, de cáncer de páncreas, presentando un caso que es un caso de una paciente guatemalteca que visitó a la Mayo Clinic y que ejemplifica muy bien el manejo contemporáneo y moderno y actual del cáncer de páncreas. Los doctores Brown, Capat y Stauffer van a hablar y van a hacer su presentación en inglés. Así que pues vamos a estar traduciendo algunas cosas. No nos va a dar tiempo de todo, pero vamos a ir tratando de traducir. Y las preguntas que ustedes vayan haciendo, por favor, las pueden poner a través del botón de chat o el botón de Q&A. Y vamos a estarlas abordando al final de la presentación, cuando vamos a abrir el panel, y también vamos a tener la participación de algunos expertos de parte de nuestra institución. Así que le doy la bienvenida a los doctores. Desde ya les agradezco su participación en nuestros programas educativos de Integra Cancer Institute. Y por favor, el doctor Frank Lucas, bienvenido.
Muchas gracias, Eddie. Es un placer para mí participar en esta actividad educacional, y tengo 2 compañeros míos que nos van a ayudar a hacer esta plática lo más ameno posible y informativa, ¿no? Quiero dar una introducción. Tengo a mi compañero gastroenterólogo Bamik Brombat. Es médico gastroenterólogo especializado en endoscopía avanzada, incluyendo en ultrasonido endoscópico, enteroscopía doble balón y pancreatología. Es profesor asistente de medicina aquí en la Escuela de Medicina en la Clínica Mayo. Es compañero mío y yo fui su mentor, y pues estoy muy agradecido que nos haya brindado su tiempo para ayudarnos hoy en este caso. Tenemos al doctor John Stauffer, también es jefe de la sección de cirugía pancreático-biliar aquí con nosotros en la Clínica Mayo en la Florida. Es profesor asociado de cirugía de nuestra Escuela de Medicina en la Clínica Mayo. Excelente persona, excelente, muy talentoso, y agradecemos pues su ayuda en participación. Como ya ha mencionado Eddie, yo soy médico gastroenterólogo, también endoscopista avanzado hepatobiliar, pancreático biliar, y soy jefe del posgrado de gastroenterología general y gastroenterología avanzada, endoscopía avanzada. Entonces, comencemos. Yo creo que ese es un caso muy interesante que se nos fue referido por parte de Guatemala, en Guatemala, para nosotros. Y vamos ahora pues compartir esto. No sé si pueden ver bien. Bueno, es un paciente que yo vi, que fue referido por nosotros por una masa pancreática. Es una paciente de 77 años de edad que fue referida por la evaluación de una masa pancreática en el proceso uncinar de más o menos 1.9 por 1.6 centímetros, que se le encontró en una tomografía computarizada y resonancia magnética. Estas fueron ordenadas como parte de la evaluación de un dolor abdominal leve en el cuadrante inferior izquierdo, que eventualmente resolvió sin ningún problema. Sin embargo, pues se hizo este estudio y se le encontró este hallazgo que podríamos decir que es incidental. No presentaba ningún otro síntoma, a excepción de pirosis ocasional, algo crónico y un poco de estreñimiento. No había pérdida de peso. En general, pues estaba asintomática. El hermano, importantemente, falleció de un cáncer pancreático a los 69 años de edad. Incluso fue mi paciente, pero él pues tenía un cuadro más avanzado y pues no fue un tratamiento adyuvante, paliativo, lo cual se le efectuó. Sus antecedentes médicos: tenía hipertensión arterial bien controlada, tenía apnea obstructiva del sueño con su CPAP sin ningún problema, tenía estreñimiento y en general pues medicamentos no tenía mucho. Estaba tomando su esomeprazol para su reflujo, que estaba bien controlado, su leche de magnesia para su estreñimiento, y pues no consumía bebidas alcohólicas, y tiene una historia remota, haber fumado hace unos 20, 30 años, pero en el momento de la presentación no fumaba. Sus antecedentes familiares, importantemente, como habíamos mencionado, tenía una historia de un adenocarcinoma del páncreas, el hermano, a la edad de los 69 años. Es más, su esposo, aunque no es familiar, su esposo, el esposo de la paciente, también fue diagnosticado con cáncer de páncreas, o no era directamente familiar, pero había una historia bastante fuerte en su familia, por lo menos para sus hijos, de tanto el padre como la madre con cáncer de páncreas. Su revisión por sistemas fue básicamente negativo, no tenía pérdida de peso, no tenía ningún otro síntoma en general, y el examen físico pues no contribuyente, normal. Sus laboratorios que se efectuaron, pues una hematología completa normal, sus electrolitos, su sodio, su potasio, función renal, su glucosa normal. Este paciente no presentaba diabetes. Muchas veces tenemos que estar pensando en pacientes que tienen diabetes como presentación inicial de un cáncer de páncreas. En este paciente su hemoglobina glicolizada y su glicemia en ayunas fue completamente normal. Ligera elevación de transaminasas y una fosfatasa alcalina básicamente entre límites normales, ligeramente elevada, pero su bilirrubina, su albúmina, su lipasa, su amilasa, normales. Tenía un CA19-9 normal, 13, normal aquí es menos de 35. Entonces, con este hallazgo nosotros pues decidimos hacer un estudio de imagen. Aquí preferimos la resonancia magnética. La tomografía igual, los dos son muy buenos, pero en nuestro protocolo usualmente la resonancia magnética, la cual preferimos. La resonancia magnética demostró que había una masa de 2 centímetros en la porción inferior de la cabeza del páncreas. El conducto pancreático estaba dilatado, pero se podía definir bastante bien en la resonancia magnética. El colédoco estaba normal, no había una obstrucción distal, o sea, el paciente no tenía involucramiento de colédoco con respecto a la masa pancreática. Los pequeños quistes pancreáticos periféricos al ducto, que no había ninguna característica fuera preocupante, serio. Los vasos sanguíneos, importantemente, no estaban involucrados por esta masa, tanto la arteria y las venas mesentéricas. La arteria la celíaca, el tronco celíaco no estaba involucrado. No había ninguna metástasis hepática. Entonces, este paciente, pues, pocas veces vemos estos pacientes que presentan con un cuadro que realmente, potencialmente, fuera resecable. Tenemos aquí la resonancia magnética y, como podemos ver con las flechas, nos orientan a una arteria mesentérica superior bien definida, igual que la vena mesentérica superior, y la masa en medio de las flechas amarillas bien definida, tanto en el corte coronal como corte sagital. Este es el colangiopancreatograma por resonancia magnética, lo conocemos en MRCP. Podemos ver el colédoco ligeramente aumentado de tamaño, 8 milímetros. Podríamos ir casi normal con la vesícula intacta. El conducto pancreático se puede definir bien, ligeramente dilatado, con áreas donde hay un poco de evidencia de que hay una lesión cística pequeña al lado, pero en general no había ninguna obstrucción, ninguna estrechez en lo que es el contorno del ducto pancreático. Entonces, las preguntas que nosotros nos hacíamos y nos hicimos, bueno, basado en el hallazgo que tenemos, ¿será esa es una lesión resecable o no? Si es resecable, ¿cuándo hacemos la resección? ¿Mandamos al paciente directamente a cirugía o hacemos algo más, como por ejemplo una terapia neoadyuvante? Y pues, ¿cuál es el rol del ultrasonido endoscópico para el diagnóstico en este paciente? ¿Qué pensamos de un CA19-9 que es normal y qué significado tiene esto con respecto al pronóstico? En fin, Yo quisiera mandar ahorita y darle la oportunidad para el doctor John Stauffer para que él nos dé una idea más o menos qué es lo que nosotros vemos aquí en un paciente, qué hacemos con un paciente que tiene una lesión como esta. So John, I'm going to go ahead and give this to you. We're going to talk about what we've discussed before about the role of neoadjuvant therapy with the resectable, not neoadjuvant therapy, and then we'll move on forward with Bombing in regards to the role of endoscopic ultrasound. The share screen.
Ya. Diego, dejémosle. Ahí estás. Muy bien. Welcome, Dr. Stauffer.
You're on mute, John. There you go.
There we go. Thank you. Thank you for the introduction, and thank you for the opportunity to discuss the management of pancreas adenocarcinoma that we do here at Mayo Clinic. I'm sharing my screen. Can you see it?
Yeah, I guess, can you go ahead and put it on presentation view? I think you just have it on just standard PowerPoint.
How about that?
Yeah, heard it. Thank you.
Great. Okay, thank you very much again. So the surgical evaluation of patients with pancreas adenocarcinoma, I kind of think of it as fitting into 4 different categories of number 1, patient fitness, number 2, any complicating factors, the oncological concerns, and then number 4, the anatomic factors. As far as the patient fitness, I do look at the physical exam, but it's really the eyeball test. I look at the patient and see what kind of vigor they have within them. It's really, I feel that just seeing them and meeting them really means a lot. And looking through their comorbidities is important. Sometimes I'm not as worried about heart disease, lung disease as alcohol abuse or nicotine abuse. Sometimes those are even more important. But comorbidities, there's very few comorbidities that holds us up from treating a patient with pancreas adenocarcinoma. And of course, there's complicating factors such as previous surgery of the patient, altered anatomy. We have a lot of patients with obesity. It's a major concern here, as well as most likely Guatemala. We have a significant amount of patients with previous Roux-en-Y gastric bypass and other altered anatomy that may come into play here. Frank, do you need to translate any of this, or do I just keep going?
I would say you could keep on going. If they have any questions, I can clarify that in general. Thank you.
Okay. And of course, there's social concerns. There is family support issues. We have a lot of patients that are independent here in the United States, that they live alone. So a lot of times we have to figure out their support and who's going to be with them afterwards. There's travel concerns. Many of our patients are from several hours, if not several states or countries away. And probably most importantly, there's oncological concerns. We need to rule out stage 4 disease. This is sometimes more difficult than what it sounds, because stage 4 disease is the most common presentation of pancreas adenocarcinoma. Particularly here at Mayo Clinic, Florida, we use magnetic resonance imaging. We have high quality MRI. While CT gives you just as good conspicuity and anatomic detail as an MRI, for the tumor itself, the advantage of MRI is really within the liver, because that is the most common distant failure of pancreas cancer, is metastatic disease to the liver. So that's why we highly, highly favor MR over CAT scan here in Mayo Clinic, Florida, because we have many different phases, including diffusion weighted imaging, and the venous and the arterial phases, and multiple in-phase, out-of-phase sequences that really find these very small lesions before at a much better rate than CAT scan does. And of course, for patients with significant weight loss, abdominal pain, or elevated CA19-9, there's high concern that there is occult metastatic disease. As far as the anatomic factors, there's resectable, borderline, and locally advanced tumors before you get to metastatic tumors. There's several definitions of these categories, and I don't particularly use a single one, but I kind of, in my head, this is how I think of them: as resectable when there's absolutely no vascular involvement, no concerning lymphadenopathy. It's straightforward, very resectable. The borderline cases usually have significant interface with the portal vein or SMV, but they also may have mild interface or abutment of the arterial system, whether it's the superior mesenteric artery or the hepatic artery. Those are generally the borderline cases. And then the locally advanced cases, we see narrowing or even occlusion of the portal vein with complete portal venous cavernous transformation, or significant arterial involvement with circumferential involvement of the celiac, or circumferential or near circumferential involvement of the SMA, or also concerning lymphadenopathy would be considered locally advanced here too. So for this patient and these 4 factors, I looked at her fitness. She's very healthy. She had some sleep apnea, hypertension, but she was able to walk to the visit. She was walking up and down the stairs. She was a very fit patient. We see many fit patients even in their 80s and 90s. So 77 is about an average patient. I see many, many patients in their 80s and even 90s that we perform pancreatectomy on, and they actually do quite well. Sometimes these 80-year-olds and 90-year-olds that are healthy and have lived a healthy lifestyle do better than the patients in their 50s and 60s who have not had a healthy lifestyle. As far as complicating factors, she's had no previous upper abdominal surgery. She has excellent family support and medical care. She was from Guatemala. She had excellent care at home. As far as her oncological concerns, as Dr. Lukens showed, the MRI did show a 2-centimeter lesion in the head of the pancreas, but there was no liver lesions, and it was a very discrete lesion. She had no significant weight loss or severe abdominal pain, and the CA19-9 is normal. As far as her anatomic factors, this lesion in the head of the pancreas was absolutely resectable by MRI, and I can show this MRI here and show you exactly what I look at and evaluate as far as surgical resection. She did have aberrant vascular anatomy with a replaced right hepatic artery, and I can show that here. This is her MRI, and again, this is one of the 25 phases of the MRI. This is the portal venous phase. This is most similar to a CAT scan. But as we follow this, we see the portal vein coming together here. And as we move down, we see this artery behind the portal vein here. This is actually the replaced right hepatic artery. As we watch it, it actually enters in the SMA. The SMA is right here. And as we go up a little higher, there's the celiac. And this is the right hepatic artery. So we're heading down. Again, we see this replaced right hepatic artery. And if you follow it into the liver, it goes right behind this bile duct here. So this is very important for the surgeon during his surgery, because we have to transect the bile duct about right here. And this aberrant right hepatic artery can be transected if you're not aware of it or do not detect it intraoperatively. So as you see, we come down, the SMV is right here. It's below where the splenic vein comes in. So we're watching the SMV here. It has a nice plane of fat around it. So does the SMA. The SMA is well away. And as we're watching the head of the pancreas, here's the dilated pancreas duct and the common bile duct here. And as you come down, we see kind of in the inferior head of the pancreas is this 2-centimeter lesion. Again, it's a relatively discrete lesion and is well away from the SMV and SMA. And this makes this a very, very resectable lesion. So when you talk to the patient about the treatment of pancreas cancer. It's really a trimodal, multidisciplinary treatment paradigm that we use, as well as everyone, of course, in the world, combined of chemotherapy, radiation, and surgical resection. And I would say of all of these, especially for resectable patients, number one of importance is the surgical resection. There's no cure without surgical resection. But chemotherapy for sure has a role in these patients because, you know, the recurrence rate is so high, the distant failure rate is so high. There's a, 60 to 75% chance of distant recurrence, which is metastatic disease at presentation. So this is, chemotherapy is a very vital part of the multidisciplinary treatment of pancreas cancer. And number three is radiation, which we use frequently, but usually in the neoadjuvant setting. Adjuvant, we usually use if there's a worrisome margin, or if there's lymph nodes, or if there's other confounding factors. But radiation in the adjuvant setting is somewhat falling out of favor unless there's extenuating circumstances. So this is our algorithm for the diagnosis and treatment of pancreas cancer. Again, for resectable cases, generally they have always gone to surgery, and we've been using this algorithm for maybe 10 to 15 years. And for the borderline cases, we go to neoadjuvant chemotherapy or chemoradiation therapy prior to surgery. And for those with advanced or locally advanced disease, generally it's palliative chemotherapy. However, over the past 2 to 3 or 4 years, we've kind of made a little bit of a shift in this treatment algorithm. For resectable cases, we have actually started using more and more neoadjuvant chemotherapy, even for resectable cases, as well as chemoradiation therapy, and then surgery, and then occasional adjuvant therapy, and sometimes surgery is the final step. And even for advanced cases, especially for locally advanced, but even metastatic cases, and we will give them neoadjuvant chemotherapy or even chemoradiation therapy and observe them for 6 months, 9 months, or even a year, sometimes even longer, and then consider for select cases, again, those patients with good biology to performing surgery and surgical resection, or even surgery with adjuvant treatments such as IRE, which is irreversible electroporation, as well as IORT, which is intraoperative radiation therapy, as well as metastasectomy, where there's a single or just a few, maybe 1 to 3 lesions in a single organ like the liver or the lung, where they can be definitively treated with resection, radiation. We occasionally perform metastasectomy for oligometastatic pancreas adenocarcinoma. And the rationale behind using this neoadjuvant chemotherapy in a more aggressive fashion are mainly 3 studies and our experience. One of these studies is a meta-analysis of 38 studies with over 3,000 patients. Half of them received neoadjuvant chemotherapy. And in an intent to treat survival analysis, there was actually significantly increased survival for those undergoing neoadjuvant chemotherapy, 18.8 months versus 14.8 months. What they noted for the neoadjuvant chemotherapy patients was there was a lower resection rate, meaning that there was patients who received neoadjuvant chemotherapy but did not end up undergoing surgery at a higher chance than those that did not get chemotherapy. And this is the concern for some people regarding neoadjuvant chemotherapy. But for the patients that had surgery, there was higher R0, meaning margin negative rates. There was lower lymph node disease, and overall there was much improved survival. In fact, if you looked at those who underwent resection, the survival advantage was actually much greater at 26.1 months versus 15 months. It was mostly a gemcitabine-based chemotherapy, and most patients received radiotherapy. So their conclusion of this meta-analysis is that neoadjuvant chemotherapy did improve survival. And this is a phase 3 trial by the Dutch Pancreatic Cancer Group, the PRIO-PANC trial, which compared 119 patients undergoing neoadjuvant chemotherapy versus 127 patients undergoing upfront surgery. The neoadjuvant therapy patients, again, had better margin negative resection rates, had better disease-free survival, as well as local regional control. Again, lower lymph node positivity rate, as well as the lymphovascular invasion and perineural invasion was lower. We see that pretty frequently in our own experience, that patients frequently do not have any positive lymph nodes after neoadjuvant chemoradiation therapy. However, in this trial, there is no difference in overall survival. I believe it was underpowered, but there was no difference in overall survival. And this third study that I want to discuss real quick was a phase 2 trial of FOLFIRINOX versus Gem/Abraxane in resectable and borderline cancer patients. Actually, it's just resectable patients. And this was used in a perioperative treatment fashion, meaning they gave both neoadjuvant as well as adjuvant. But they did not see any superiority of either regime. What they did notice was most patients tolerated the neoadjuvant chemotherapy very, very well and underwent safe surgery, meaning that giving chemotherapy, even FOLFIRINOX for extended period of time, did not increase the morbidity or mortality of the operation. And again, in our experience, I feel the same thing. In some ways, patients actually tolerate surgery better, and I'll discuss that here in a second. But what they also noted was adjuvant chemotherapy is difficult to complete for many patients, meaning that they had surgery, they just didn't recover well enough to receive their full adjuvant course. And again, I see that too a lot. So the main advantages of neoadjuvant chemotherapy is the fact that understaging by imaging is very common. I feel that our MRI here is top-notch, high quality, best in the world, but we still miss patients with micrometastatic disease. It increases the chances of full multimodal therapy, and just like I said, patients after Whipple or after major pancreatic resection sometimes just don't tolerate the adjuvant chemotherapy or radiation and have to cut it short and don't receive the full course of adjuvant therapy. It increases the margin positivity rate, which is one of the most important factors when you're looking at overall long-term survival and prognosis. If you can get a margin negative operation, it's generally much better survival than a positive margin resection. Giving neoadjuvant chemotherapy improves your patient selection. You don't want to put a patient through a futile operation. If these patients progress rapidly on neoadjuvant chemotherapy, you never would have helped them with any type of surgery. So these patients, it's good to know if the tumor biology is just so poor that they're not controlled by several months of neoadjuvant chemotherapy, these patients do not need to be in the operating room. There's earlier treatment of occult metastatic disease, which is, again, the recurrence rate is 75%. So it would make sense that 75% of patients that show up to your clinic with pancreas cancer already have metastatic disease. And really the first thing you need to treat them with is systemic chemotherapy. And again, I feel that we are seeing improved surgical outcomes. A lot of times patients present to us, they're out of shape or they are deconditioned from their disease and the presentation of their disease. And despite undergoing chemotherapy, many of these patients actually improve their physical fitness prior to surgery. Additionally, the chemotherapy, the resulting desmoplasia, especially with tumor regression, as well as the radiotherapy, oftentimes hardens the pancreas. And the harder the pancreas is, the easier it's to sew to. The easier to sew to, the less chance that it's going to leak. And the leak is really the driver of most of the morbidity and mortality after pancreatectomy. So the less that they leak, the better they do. And the more radiation and chemotherapy they get, usually the less they leak. So this patient was offered upfront surgery. She was resectable again, but we also sent her to our oncologist to evaluate for neoadjuvant chemotherapy, which after discussing with her family and the oncologist, She chose neoadjuvant chemotherapy, and they chose gemcitabine with Abraxane. But because they chose chemotherapy, they actually needed a biopsy. We know that what this is. We could recognize it on MRI, but to undergo chemotherapy here in the United States, you have to have a biopsy that shows cancer. And this is where we pull Dr. Brombutt in.
Thank you, John. So I guess you could stop sharing your screen and we'll have Bhawmik go ahead and proceed with the endoscopic ultrasound. Bueno, el doctor Brombutt va ahora a hablarnos del siguiente paso, que en esta situación sería hacer un ultrasonido endoscópico con muestreo de la masa. Go ahead.
Gracias. Thank you for this invitation and this opportunity. Good evening, everyone. Okay, everybody can see my screen?
Go ahead,
Okay.
John. Yeah, we did.
All right. So what is the role of endoscopic ultrasound in pancreas lesion? As previously discussed, endoscopic ultrasound is one of the most sensitive, especially for lesions that are less than 2 centimeters in size in the pancreas. As also previously highlighted, the pancreas protocol MRI and the CT are best used for tumor staging and resectability. With exception of detecting portal vein invasion and subtle volume ascites or malignant ascites, endoscopic ultrasound is superior. Also for subtle hepatic metastasis, MRI and endoscopic ultrasound are superior to the CT scan, even though it's a pancreas protocol CT. So now we have to take biopsy of this pancreas lesion. How would you do it? Would you do it endoscopic ultrasound guided, or would you do it CT scan guided? Endoscopic ultrasound guided biopsy has less needle tract seeding, therefore less peritoneal carcinomatosis, and is also cheaper than CT scan guided biopsy. One of such example to support the evidence is in this meta-analysis of almost 11,000 patients, where endoscopic ultrasound guided biopsy of the pancreas mass was deemed to be generally safe, as the overall adverse event was 1% and less than 0.5% risk of acute pancreatitis or abdominal pain after the procedure, and much rare other adverse events such as bleeding, fever, or infection. The tumor seeding with endoscopic ultrasound guided biopsy was up to 2%. In comparison to CT scan guided pancreas biopsy was more than 16%. So this is the endoscopic ultrasound image of our patient, which was done in April 2019. And we can appreciate here subtle hypoechoic mass about 2 centimeters in size. And this is the border of the uncinate process. And this is the mass. This is a different plane of the same, but we can appreciate that the pancreas duct is coming into view. Here we can appreciate it being so close to the common bile duct and the pancreas duct. And that is what made her lucky, because this lesion was close to the ampulla. That means close to the common bile duct and the pancreas duct. That why it became relatively symptomatic earlier. If this was much further away, by the time the symptoms start, it may be too late with obvious distant metastasis. As we know, endoscopic ultrasound gives us an advantage of applying Doppler, which helps us find an avascular window when we have to take a biopsy. Here again, we can appreciate the common bile duct and the pancreas duct. We can also use endoscopic ultrasound guided elastography, where, as we know, adenocarcinomas are hard. And here we can appreciate the hardness of the pancreas cancer. The blue marks it is hard and the red is soft. So this is the background. It comes in especially handy when patients have background of fatty pancreas, when it is very hard to see with poor echo penetration of the ultrasound probe. And there we can apply this elastography and we can find subtle lesions. We yet do not have endoscopic ultrasound contrast. In Europe, it has been approved. We actually at Mayo, Florida are doing a safety trial, and hopefully within a year or two, FDA will clear it to use it. and that will allow us to pick up even more subtle lesions. So now the question comes, should we do a fine needle biopsy, such as a core biopsy, or a standard fine needle aspiration? There's no difference in the gauge of the needle. It's the same gauge. The difference lies, instead of being a standard bevel, which is in the aspiration needle, if we just change the shape and the cutting surface of the edge of the needle, we can change it into a core sampling and changing the texture of the shaft. If we take a core biopsy, such as a true cut biopsy, now we have core needles, so we don't have to use true cut needles, which gives us similar benefits. We get a good core sample where we get enough stroma, whereas in the aspiration needle, we get very fragmented pieces. So one such example to compare this, in this study, 166 patients of solid pancreas lesion, the fine needle biopsy had a higher diagnostic yield, about 99% compared to 92% of aspiration needle. The core biopsy needle, the number of needle passes required were lower. That means lower complication. 3 versus 4 passes for final aspiration to come to diagnosis. So core biopsy is considered when previously an FNA or fine needle aspiration has been performed and it was not diagnostic. And the other advantage of core biopsy is that it gives us additional tissue, so we can do more studies such as molecular testing, which is now becoming a standard of care in majority of the centers across the world. So we're going back to our patient. Now we can see our needle passing in. Then what we do, once we pass the needle, we use the same puncture site and use a fanning technique. Whereas in comparison to multiple passes, we have to make multiple punctures. So this increases the risk of complications or post-procedural adverse events, and this minimizes it. This is a core sample that we got just from one single pass from using such core needles. We also have on-site touch cytologists, which are present in the room, and they can prepare a quick smear, and they can tell us if our sample is adequate and if it's going to be diagnostic or not. This minimizes the delay in the care of the patient. This also minimizes the number of procedures required, and we can have a preliminary answer for the patient and the family as well. So now I will hand it over to Dr. Lukens, who will review the final path report and take it from there.
Thank you, Bibi. So let's go back and let me go ahead and share my screen again. So la patología, tenemos ahora, un momentito ahorita, tenemos la patología, ahora tenemos por las laminillas que mostraron células atípicas consistentes con una neoplasia. Parte del tejido que se aspiró con la aguja se mandó a histología y podemos encontrar también células atípicas consistentes con adenocarcinoma en esta fase. Basado en esto, como habíamos mencionado, el paciente prefirió una terapia neoadyuvante, lo cual fue Abraxane con gemcitabina por 3 meses. Ese era el plan, 3 ciclos, día 1, 8 y 15, con 2 semanas de descanso. Sin embargo, después del segundo ciclo, la paciente no toleró bien la quimioterapia y se suspendió, debido a que la paciente demostró neutropenia, fatiga y debilidad generalizada, así como diarrea. Entonces el plan fue proceder con cirugía. John?
Yes. Can you see my screen?
Not yet.
Okay. How about now?
No.
Oh,
No.
there we go.
Now there we go.
Okay. Okay, so this patient, again, was considered for pancreatectomy and had a tumor in the head of her pancreas, as we had seen previously. So we performed pancreatic duodenectomy. This is a schematic of the resection itself, where the gallbladder is removed, the head of the pancreas with the tumor, as well as the near entire duodenum, as well as proximal jejunum. We generally perform a pylorus preserving pancreatic duodenectomy with reconstruction that you can see here. The remnant pancreas is sewn to the proximal jejunal limb, as well as a distal hepaticojejunostomy with a downstream anticolic duodenojejunostomy. This particular one we performed laparoscopically using a 6 trocar technique. Again, pylorus preserving with reconstruction as described. This is our patient positioning and surgeon positioning. We generally move from the right side to the middle to the left side of the patient. And the trocars, we have a main Hassan trocar with several trocars placed in an array around the head of the pancreas. These are some just quick pictures. This is the hepatic artery going into the hilum of the liver, the gastroadrenal artery, the underlying portal vein here, and the head of the pancreas down here. This is the actual pancreas itself. This is the main pancreas duct. This is not the same patient, so this patient's main pancreas duct is actually quite small, and it's very difficult to reconstruct. This is the reconstruction of the bile duct to the jejunum, which is usually performed first. This is the reconstruction of the pancreas, which is right here on the right, to the jejunum, which is here on the left, and this is the main pancreas duct using small needles to sew it to a hole in the jejunum here. And this is sewing the duodenum here. We usually leave just 1 to 2 centimeters cuff of duodenum past the pylorus to the jejunum. It's a 2-layered anastomosis. So she did well. No complications were noted in her postoperative period. She had her diet advanced and her drain was removed, and she was discharged on postoperative day number 5. Had a small readmission for nausea, which resolved, and she returned home within several weeks to start her adjuvant chemotherapy at home. Do you want to do follow-up, or do you want me to show her follow-up at 1 year with a CAT scan? Oh, I think you're muted.
Sorry, you can go ahead and do some of it. Yeah, that'll be fine.
Okay.
I'll just go into details afterwards about what kind of chemotherapy and all that. Yes.
Perfect. She finished her adjuvant chemotherapy. We saw her at 1 year. There was no signs of recurrence or metastatic disease. This is her follow-up CAT scan. As you go down here, you see multiple clips from the surgery itself. There's actually a pancreas duct stent here, which is a 3.5 French pediatric feeding tube that's used to facilitate the anastomosis, and it stayed in her. Sometimes these pass spontaneously, but this looked good. Her vein was wide open. Her artery was again well away. So her CAT scan looked good.
Thank you, John. Appreciate that. Hold on. See if I can share a screen here. And here we go. El paciente, como mencionó el doctor Stauffer, efectuaron una pancreatectomía laparoscópica con perforación pilórica y colecistectomía. Y el curso posoperatorio, pues no complicado con ingreso hospitalario al día número 5. La patología final demostró un tumor de 2.2 centímetros, localización en la cabeza del páncreas, tipo histológico era un adenocarcinoma. La extensión del tumor invadía la pared duodenal y el tejido peripancreático. Sin embargo, los márgenes eran negativos para el tumor. No había ninguna invasión linfovascular y había invasión perineural presente. De los ganglios linfáticos, los 19 obtenidos, ninguno estaba involucrado. Vemos aquí imagen de lo que es la patología con células típicas y compositivas para cáncer cerca de lo que es el tejido adiposo peripancreático. Y también aquí en la pared duodenal había infiltración en el área submucosa, no en la mucosa todavía, pero definitivamente había infiltración de adenocarcinoma en esta área. Al final era un tumor T2, N0, M0, estadio 2A. Se decidió darle Xeloda debido a que había intolerancia a la quimioterapia neoadyuvante que se le había efectuado antes de la operación. Y la recomendación es darle 6 meses, 8 ciclos en total, a la dosis de 1 gramo 2 veces al día, 2 semanas con 1 semana de descanso. Pero por efectos secundarios debido a diarrea, dermatitis, estomatitis, se modificó a 1 semana de tratamiento con 1 de descanso y 6 meses después se dio la resonancia, se recomendó hacer una resonancia magnética cada 6 meses por 5 años y como vimos, y John ya demostró pues, que no hubo, a los 6 meses de postoperatorio la tomografía computarizada no demostró ninguna recurrencia. Aquí tenemos los cortes donde se puede notar, basado en la primera slide, la anastomosis el pancreatoyunal. Y también podemos ver el stent pancreático de 3 French que se puso en el ducto pancreático que nos ayuda a asistir para evitar las fugas pancreáticas en pacientes postoperados. Aquí vemos otra vez el magnificado, lo que es el corte, donde está la anastomosis. Se puede identificar que no hay ninguna recurrencia de tumor a los 6. Ahora, a los 6 meses. Ahora la pregunta, pues ya para terminar, Baumek nos va a ayudar a tratar de resolver esta pregunta, en la cual los hijos de la paciente nos preguntan qué pueden hacer ellos, qué podemos hacer para prevenir o detectar un cáncer pancreático, ya que tanto su mamá, el hermano de la mamá, el tío materno, como su papá le fueron diagnosticados cáncer pancreático. Entonces, Bibi, I'm going to go ahead and give this back to you.
Okay, thank you.
So we can give us a little bit more about how we can take care of this and maybe prevent somehow and how we can approach this.
Yes, thank you. Can you see my screen?
Yes, we can go ahead and see it. Thank you.
Okay. So why prevention is better than cure? Because as we can see here, it is projected that by 2030, pancreas cancer will be the 2nd leading cause of cancer-related deaths, at least in the United States. And a similar trend is expected in most of the countries across the world. Why prevention is better than cure? Because it has a very challenging tumor biology. It has drug resistance. The stroma acts as a barrier to most drug to be delivered. It has a complex and a poorly understood microenvironment. It has multiple genetic mutations to handle. It is considered to be non-druggable tumor, especially because of the suppressor genes, and has no reliable biomarker. As in our example, despite having a symptomatic tumor, her CA19-9 was normal. So the sensitivity and specificity of a CA19-9 is approximately 80%. There are several false positives and false negatives. One of the reasons of false negative is Lewis antigen in the blood. We know now that the patients who do not express Lewis antigen in the blood, they may not express or mount a CA19-9 response. Why prevention is better than cure? Again, poor prognosis. The 5-year survival after surgery is 10% if the node is positive, even if a single node is positive. And it's up to 30% for node negative disease. So, do you know from a normal ductal epithelium, from when the first mutation happens, and then it leads to PANN, PANN2, PANN3, and cancer, before it metastasizes, how long does it take to go from here to here? The answer is from first mutation to invasive cancer, it takes 12 years. Multiple studies have shown this. So our imaging studies are not as good. But however, some new studies are coming up that the sensitivity of CT scan is not good for smaller lesions. But now when we look retrospectively to a lot of these MRIs or CT scans from the diagnosis that was made, and we look for prior CT scans or MRIs before the final diagnosis was made, up to 90% of the MRIs and up to 50% of those CT scans have some abnormality on an average 17 months prior to the diagnosis. So as the quality of the images is improving, as the artificial intelligence is increasing in the software of these imaging studies, we are detecting it sooner, but still we are not doing a good job. So that's where the molecular study researchers are going on to look for subtle biomarkers or subtle DNA or RNA products in the pancreas juice or in the stool or in the blood. And then a lot of research going on, but no, so there's a lot of promise in the next 5 to 10 years, but still nothing definitive. To understand prevention, we need to understand risk factors of pancreas cancer. On the left, there's so-called somewhat non-modifiable age. A median age is 71 years of presentation. What can we do to postpone this much later in life? Not significant gender difference. Subtle increased risk in blacks than in whites. However, this is probably because of the lifestyle. It's more common in developed countries and high-income North Americans, and it's slightly more common in non-O blood groups. On the right, there are modifiable risk factors. BMI greater than 23, mind you, not BMI more than 25, but BMI more than 23. Diet, tobacco exposure, alcohol and caffeine, or sorry, coffee. Chronic pancreatitis, diabetes, H. pylori history, chronic hepatitis B and C, genetic history and pancreas cyst. And why do I say plus or minus here? We'll talk about that. About 5 to 10% of cancers, pancreas cancers, have genetic basis. And up to 10% of pancreas cancer patients have a first-degree relative. So if a baseline relative risk with one first-degree relative is X, then in comparison to 2 first-degree relatives, it is 6.4 times the risk, as a Tenar patient was asking. In 3 first-degree relatives, the risk jumps up to 32 times. However, I want you to look at glass half full, not empty. Despite having 3 first-degree relatives, it is not 100%. It's only 32 times. And this slide will give you a perspective. First, let's focus at the bottom. Let's say if somebody has no family history of pancreas cancer, and that has a relative risk of 1, them developing pancreas cancer is less than 0.05% at the age of 70 and 0.06% at the age of 17. At the age of 50, it is less than 0.5%. If the patient is a smoker, the risk is 1.5 times. But this is very interesting. If the BMI is more than 23, it is even more than a smoker, 1.8 times. So this is an important take-home point. Now, in comparison to no family history, and you compare all the commonly known genetic mutations, which has increased risk, and this is the relative risk, how many times the increased risk is. The highest is with Peutz-Jeghers, 132 times. Even in them, the risk of getting pancreas cancer at the age of 50, the highest is about 6.6%. And their risk of getting pancreas cancer at the age of 70, the highest is 40% in hereditary pancreatitis. But again, I want you to look at this as glass half full. Despite having a genetic curse, not 100% of them, they develop pancreas cancer even at the age of 70. Isn't that amazing? So that itself should give you goosebumps, okay? And let's understand why. And let's understand why there is variable penetrance. But just briefly to touch base upon pancreatic steatosis in a pre-diagnostic CT scan. So our group at Mayo Clinic, Florida studied this, and we found that obesity and visceral fat deposition may play a role in pancreas cancer. We also found that this pancreas steatosis was seen in these pancreas cancer resection specimens, and it was seen on the CT scan at the time of diagnosis. So we suspect that fatty infiltration either an early sign of or a risk factor for pancreas cancer. However, larger sample size is necessary to make firm conclusions. As we reviewed, only a small percentage of all human cancers are purely genetic. So genetic is overrated. However, the rest involves the external factors, particularly our own diet. Okay, why? Because the genes are overrated. However, the epigenetics is where the focus should be. And who controls the epigenetics? Epigenetics is a switch which turns on or off the gene. Okay, and who controls the epigenetic? Environmental stimuli. Now, in terms of environmental stimuli, if you look at our body surface area, even if you take out our lung, and if you take out each and every alveoli and you put it flat, and you take the skin and you put it flat, and you combine that surface area of both lung and skin, and you compare it with the gastrointestinal surface area, and you count each and every villi and you flatten it out, the GI, the gastrointestinal surface area, is 1,000 times more in comparison to lung and skin combined. So that is where we have the highest control of the epigenetics of any tumor. But for this instance, let's stay to pancreas cancer. So now we know that the Western diet pattern, which is high in saturated fat and or meat, particularly smoked and processed meat in comparison to raw meat, has been linked to development of pancreas cancer in many studies over and over again. This is just very few of them, which I have listed at the bottom. One such example, let's briefly review wart-causing poultry viruses. So the coronavirus, so I thought this would be interesting for the audience, or at least the audience will take it now seriously. But these studies have been shown there in early 2011 and 2010, and even prior to that. But now people will perhaps take it a little more seriously. So this study was done in 30,000 poultry workers, and we found that they had increased risk of deaths from liver and pancreas cancer. And who slaughtered the chickens amongst these poultry workers, they had 9 times the risk or the odds of getting both liver and or pancreas cancer. And mind you, just to compare this, in somebody who smokes cigarette for 50 years every day, their risk of pancreas cancer is only 2 times the odds. And this is 9 times the odds, okay? So this is not coincidence. What about people who don't slaughter and they just eat chicken? So Europeans answered this. So the European Prospective Investigation into Cancer Nutrition, known as an EPIC study, they studied 477,000 people for about a decade. They found that there is a 72% increased risk of pancreas cancer for every 50 grams of chicken per day. So what does it translate to? That translates to less than 2 ounces. That means just about a quarter of a chicken breast. And that increases the risk of pancreas cancer by 72%. Okay. In the same group, they also found increased risk of lymphoma and leukemia. It's no surprise because viruses it's a risk factor for the lymphoma and leukemia as well. So the authors, they concluded that the growth promoting drugs fed to chickens and turkeys and the cancer causing viruses found in the poultry could be the etiology behind this. What about red meat? One pathogenesis is that once we have sufficient amount of iron in our blood, our body is about 5 times more effective in blocking the absorption of excess iron from plant foods in comparison to animal foods. Okay, so this may be why heme iron, which is the animal source of iron, is associated with cancer and heart disease risk. Similarly to what we see in hemochromatosis patient, and we see that same presentation in general patient without hemochromatosis. Similarly, a heme iron, which is animal-based iron, is associated with higher risk of diabetes. We know that is one of the risk factors for pancreas cancer, but not the non-heme iron, which is the plant source of iron. There are several case control studies report a protective effect from consumption of fresh fruits and vegetables. Okay, are probably our grandmothers or uneducated great-grandparents. They kept on telling us, eat more fruits and vegetables. Even without education, they know sometimes more than what we have perceived. The consumption of fat from all fat sources, from all animal sources was significantly associated with pancreas cancer risk, but no correlation was found with consumption of plant fat. Okay, so that's important. Again, a lot of data, this is only some of them. So our best bet for prevention of pancreas cancer is to avoid tobacco, avoid excess alcohol intake, avoid obesity, and to eat diet low in animal products and low in refined grains and low in added sugar. However, we should take diet rich in beans, lentils, split peas, and dried fruits. Now, why these? So Petri dish studies, it showed that phytates inhibits virtually all human cancer cells tested so far, including colon cancer, breast cancer, cervical cancer, prostate cancer, liver cancer, pancreas cancer, and skin cancer, while leaving the normal cells alone. This is the hallmark, or this is the best quality that you can imagine or you can hope for in any anti-cancer agent. When we eat whole grains, beans, nuts, and seeds, phytates are readily absorbed into our bloodstream and readily taken up by tumor cells. The tumor concentrates these compounds so effectively that phytate scans can be used to trace the spread of cancer within the body. Now, what are these phytate scans? These PET scans, the PET scans that we use, that's nothing but these phytates, which are radio labeled, and it finds its way and it can pick up the subtle most metastasis. So that is the power of phytate. It finds its way. It's like that a missile which senses heat. It can find a single, or well, a tumor cell as well, and I'll show you in the next slide. So phytates has a combination of antioxidant, anti-inflammatory, and immune-enhancing activities. It boosts the activity of natural killer cells. So our first line defense against tumor. So even before we can even dream, or we can ever find a molecular marker to detect this, the phytates, if we take regularly, it will kill the first mutated cell. It is that powerful, okay? The last line defense also the phytate enhances by starving the tumor of their blood supply. Sometimes also it causes cancer cells to apparently revert back to normal. It has been proven in colon, breast, liver, and prostate, not yet in pancreas cancer, but there's some research going on. Similarly, many plant compounds, or known as phytochemicals, are able to slow down and even stop cancer cell growth. Now, lot and lot data is coming out, and this is just some of them to highlight. So humans have evolved eating huge amount of fibers, at least 100 grams a day. Now we have a lot of archaeological evidence that even our ancestors were plant-eating ancestors. And if you just spend some time on Discovery Channel, you will see that the archaeologists will say, we are sorry that we got it wrong. It's just that the fossils, we found more animal-based fossils because the plants and fruits around it, they would disintegrate so fast. However, now with the advantage of carbon dating and revolution in the science or forensic science, now we know there were more fruits and vegetables around our ancestors' fossils than there were animal-based. And now we know that we found animal-based mainly when there was a famine or when they were migrating from extremes of weathers. Only then they would rely on animal-based fat or protein. So humans were evolved at least 100 grams a day. However, that is 10 times the current average. One of the other advantages of fiber in the diet is it binds with toxins such as lead, mercury, unwanted waste products, or pharmaceutical exposure that we get from meat or milk products from animals because they have exposure to several pesticides and toxins. It also binds to excess cholesterol. So any fat-soluble toxin, it will be excreted by your bile into your gastrointestinal tract, and the fiber will bind with that cholesterol and excrete it. But if you don't have enough fiber, that will keep on going in circle in the enterohepatic circulation. Okay, it also binds with excess estrogen from our own body, male or female, or from exogenous estrogen that we get from any animal-based product, including their milk and milk products. And all of that fiber, it sweeps it away. If low fiber diet, then all of these gets reabsorbed, as we just reviewed. And the surprising statistics is that only 3% of Americans may even reach a recommended minimum daily intake of fiber, making it one of the most widespread nutrient deficiencies, at least in the United States, and a similar number in most of the other countries. So in my opinion, there is enough compelling evidence to recommend and consider whole food plant-based diet as a source of nutrition in such patients for prevention and as a neoadjuvant in somebody who is diagnosed with pancreas adenocarcinoma, of course, in addition to the standard of care. So this is what I would recommend to our patient and to her family. And we also have a program at Mayo Clinic where we have such high-risk patients where we follow and we do annual visits. And annual, we do pancreas protocol MRI with MRCP and or endoscopic ultrasound. And we keep on alternating between MRI and endoscopic ultrasound on an annual basis. In some severely high-risk patients, we choose to do both. And if we see any subtle abnormality on the MRI, then we do endoscopic ultrasound to verify and to biopsy it.
Thank you, Baby. Yeah, it's wonderful. We can share that. Eddie, entonces, voy a share my screen. Yo creo que ya estamos, Eddie, yo creo que podemos ir a las preguntas.
Muy bien, excelente, pues muchísimas gracias, excelentes exposiciones de todos ustedes, de verdad, impresionante y muy detallado. Ejemplifica re bien cómo tratar a un paciente en estas condiciones, pero como ustedes mencionaban, la gran mayoría de los pacientes que vemos, pues no los vemos en estas etapas, sino mucho más avanzadas. Y tal vez ahí va la primera pregunta. Voy a hacer las preguntas en español y después las voy a hacer en inglés. Entonces, la primera pregunta que yo tendría es, ¿en qué casos o qué factores se toman en cuenta para cuando se decide dar neoadjuvancia, dar solo neoadjuvancia con quimioterapia o agregar radioterapia concomitante? So to the panel, what factors do you consider if you're going to give neoadjuvant chemo only, or you're going to give chemo radiotherapy as neoadjuvant?
John, you want to answer that?
Sure. For patients that have a worrisome margin or vascular involvement, basically those that are borderline or locally advanced, I use radiotherapy for almost all patients. So I've been using it more and more frequently. For those that are resectable, I think it's got minimal benefits, and occasionally we use it, but we use very short course radiation, like 1 week instead of the standard 5-week course.
Interesting. Very good. Usted también mencionó sobre la biología del tumor, que hay biologías que pueden ser favorables y algunas que obviamente no van a ser favorables, y que si el tumor no respondió a la quimioterapia neoadjuvante o al tratamiento neoadjuvante, pues cualquier cirugía que se haga tampoco lo hubiera beneficiado en ningún momento. ¿Qué factores o qué marcadores, tanto biomoleculares como de otro tipo, físicos, se consideran para tratar de predecir qué tumores van a ser los favorables o los no favorables? So you had mentioned before about the good biology of the tumors, and one of the benefits of giving neoadjuvant treatment is that patients will select themselves for the treatment because if they're going to progress on this treatment, no surgery was going to benefit them anyway. Do you have any markers, either biomolecular markers or other markers, physical markers, or something that you are trying, or are you studying to select these patients for this treatment because they might do better than others?
Unfortunately, no, we do not have the ability to follow them biochemically. We were following circulating tumor DNA for some time, but this really was not reliable. As Dr. Brombach was saying, there's really no serum markers that really tell us with any accuracy the level of cancer, the amount of cancer in any patient's body. And no, we are not this sophisticated that we can biopsy, test the genetics, and tailor their therapy. Basically, we have two therapies that are first line, and that's what we use. We use radiographic response, and we use very crude biochemical responses with the CA19-9 as our best marker. And of course, we're still working on more sophisticated markers, but no, we don't use them clinically right now.
Okay. What about a PET scan? Do you use at all PET scans for staging or?
Generally,
I mean, non-metastatic disease I'm
right.
talking about.
Generally, we don't. We find the MRIs are more specific and sensitive because they will find without any hesitation much smaller lesions within a liver than a PET scan, and they're also much more specific. These patients frequently present with abscesses, cholangitis, and if you use a PET scan, you'll see a lot of false positives with PET scan. So I rarely ever use PET scan. That being said, in Rochester, they're starting to use PET scan more frequently because they like to compare the tumor avidity before chemotherapy as well as after chemotherapy as a marker of the response. Again, that's a little bit more, potentially more sophisticated than just a plain radiographic size response. But we haven't really started using that yet.
Okay. We have a few questions from, regarding surgery. Open versus laparoscopic pancreatectomy. Of course, other than the experience that the surgeon might have or the preference, of course, what is what's the status right now, and in overall survivor and recovery and patient, hospital stay, etc.
Actually, in the past 10 years, I used to use laparoscopic pancreatic duodenectomy much more frequently than now. I have multiple reasons that I generally do open surgery now, but I guess first and foremost is that there was very little benefit to the laparoscopic approach. The fistula rate was higher, the complications were more, and the hospital stay was actually longer. And it turns a hard surgery into a much more difficult surgery, actually. Some patients are about the same and do well. This patient in particular was very suitable to the laparoscopic approach and desired it, which is fine. We had the whole day in the operating room because the laparoscopic approach takes at least 6 hours, whereas most open operations take 3 to 3.5 hours to perform. And it does require significant OR resources and manpower, which we just don't have the capability sometimes to do that.
Of course, it's a lot more expensive, for sure.
It is.
What about pylorus preserving work versus not? Preservación de píloro versus no sin preservar.
We generally perform pylorus preserving, not for any oncological reasons, but just in long term, we find that the patients eat more normally in the long term with pylorus preservation. There's really no significantly increased delayed gastric emptying that some people worry about, so we generally perform pylorus preserving if possible. Now, more recently, we're taking more and more patients to the operating room with more advanced tumors, borderline or locally advanced. And these patients, number one, really are not good laparoscopic candidates. So most of my patients really aren't even candidates for laparoscopic anymore. But sometimes the heavy-duty chemo and the radiation right onto the head of the pancreas will cause significant desmoplasia and really affect the pylorus. And we get a lot of ulcers. So I've kind of switched to if we're really heavily radiating the pylorus and the post-pyloric duodenum, I would actually err towards performing a standard pancreatectomy for those patients and not perform pylorus preserving.
Okay. How soon after radiotherapy or chemoradiotherapy do you suggest the patient should go to surgery?
4 to 6 weeks.
4 to 6 weeks. Okay. You know, rectal cancer, that's gone a little further, but it's still 4 to 6 weeks, and same for gastric cancer as well. In this particular patient, there was a perineural invasion. Would that have been is that a problem, or is that a consideration for radiotherapy, post-operative therapy?
It would be consideration. Perineural invasion for pancreas cancer is incredibly common. I frequently look under the microscope with the pathologist, and you can always, if you find a big nerve, you'll always find pancreas cancer tracking along the nerve. So that is, I feel that that's probably the most important role for radiotherapy, is this perineural local invasion, especially along the uncinate process by the SMA that has a lot of the bowel nerves in that area. Again, fortunately for her, her tumor was very far from the SMA, completely on the other side of the head of the pancreas. I don't really feel that radiation would benefit that this much. The perineural invasion was probably just local around the tumor, probably not in the uncinate margin. If it was in the uncinate margin, I would definitely consider radiation therapy, but radiation therapy is associated with significant side effects too. We see some perforations, strictures, and other problems from radiation. So we sometimes try to save it for patients that probably do not benefit from it at all.
Okay. And how often do you have to, go on and do a SMA resection or SMB resections, even if with a good response and they're clear, but maybe initially they weren't?
Right.
How do you make that choice? Le preguntaba al doctor que a pesar de una buena respuesta que pudiera tener un paciente con quimioterapia neoadyuvante o quimioterapia o radioterapia de neoadyuvantes, si aún harían la resección de la mesentérica superior, la vena o la arteria, o la arteria, dependiendo de cómo fue la presentación inicial. Go ahead, I'm sorry.
Sorry. So generally, I don't perform SMA resections. I feel that if there's SMA circumferentially involved, this is probably too locally advanced for resection. However, I would consider performing IRE, which is irreversible electroporation, alongside the SMA to accentuate that margin, called a margin accentuation surgery, where we perform a Whipple but accentuate that margin with an ablation. IRE is a non-thermal ablation, which is electroporation, and it causes micro holes within the cells, nano holes, and it's not as good as resection, but it may cover a margin at risk like the SMA. As far as the celiac and the hepatic artery, we will resect those. I have a case tomorrow where the celiac is completely circumferentially involved, and I'll have to resect the entire celiac axis, including the hepatic artery, splenic artery, and gastric artery. In that case, we have to perform total pancreatectomy and splenectomy, as well as total gastrectomy, due to the vascular resection that's being performed, and we have to perform hepatic artery reconstruction from the aorta. So that's pretty unusual, but we will for select patients. As far as vein resection, that's relatively common. Just today, I had a patient who had complete vein involvement with SMB circumferential involvement about 6 months ago. She underwent 6 months of chemotherapy. Her SMB was clear, it opened, it was patent, but it was touching the tumor. And what we found intraoperatively was there was still significant tumor involvement and abutment, and then we just performed a tangential resection of the SMB. So if they have vein involvement, there's still a decent chance that they may need venous resection, and that's probably about 20 to 30% of patients.
Okay. So Frank or Vivi, there's a question, I'll read it in Spanish first. ¿Cuál es la razón de que el cáncer de cabeza de páncreas es más fulminante que el del cuerpo y cola de páncreas? What's the reason that cancer of the head of the pancreas is a lot more severe than the head of or the tail? I mean, the body of the tail of the pancreas.
It's not severe. It is less severe because if it is closer to the pancreas duct or the common bile duct, because when the tumor causes a compression of these ducts, the patients have subtle symptoms they start, such as maybe exocrine insufficiency or dull pain reading to the back. So you catch them early when they're smaller in size. Whereas if they're in the body or tail of the pancreas, then they may be too big at the time of presentation with distant metastasis and most likely not resectable by that time.
Want to add anything, Frank?
No, I agree completely with Bamek. At the time, a lot of the times muchas veces tenemos pacientes que se presentan con diabetes como primera vez y les hacen las imágenes y se presenta como el típico paciente con adenocarcinoma de páncreas con ictericia sin dolor, y pues ya la mayoría de las veces ya son irresecables, ¿no? Nosotros usualmente pacientes que vienen obstruidos, eso es otra cosa que tenemos que considerar. Si el CA19-9 está elevado, descomprimimos la vía biliar y usualmente baja el CA19-9. Y cuando hacemos una paliación de tratamiento de la obstrucción biliar, utilizamos obviamente el ERCP, podemos utilizar un stent plástico, un stent metálico cubierto para hacer el periodo de tiempo necesario para que haga la terapia neoadyuvante y después llevar al cirujano al paciente a la sala de operaciones. Preferimos un stent plástico o un stent cubierto metálico que uno que no es cubierto, que es permanente, ¿no? Es más fácil para el cirujano manipular eso.
Doctora Stauffer, si el paciente es un paciente con resección, con borderline resecable, y se le da el tratamiento y tal vez no tuvo tan excelente respuesta o pudo haber tenido respuesta, pero el CA19 no bajó mucho. ¿Contraindica la cirugía el que no haya respondido tanto o no haya disminuido tanto el CA19-9? Dr. Stauffer, do you take into consideration if the CA19-9 did not go down as expected in a borderline case, would that be a contraindication for surgery, or you still go ahead even if they had an acceptable response?
No, it's not a contraindication. Again, CA19-9 is not very specific. It can go up in the setting of biliary obstruction, pulmonary disease. So we like to see the CA19-9 respond drastically and even normalize, but that would not be a deal breaker in and of itself.
Okay. Dr. Kusterman, who's a interventional radiologist here in Guatemala, he's asking, if the patient does a resection, has a resection of the celiac artery involvement, would you consider a covered stent of the celiac trunk preoperatively, or would you have a safer procedure? Would it make it a safer procedure if you put a covered stent if it had not the celiac artery, I guess he's talking about the SMB or the SMA.
Probably not. We still have to resect it. We have one of our interventional radiologists wants to try something similar to what he was describing, where if the SMA was involved, we would place a stent preoperatively and then dissect out the SMA, including the adventitia, because it had reepithelialized over time. So it's a consideration. We have not really looked into it right now, preoperative stenting, but it's definitely very interesting proposition, I think.
Okay. And one of the reasons, of course, you would go ahead and take a biopsy is because of the other common tumor, much less common, but it's still there, is the neuroendocrine tumors. How different would you approach these initially when you just do the imaging? Is there anything that specifically will make you suspect that this is a neuroendocrine and not adenocarcinoma?
Yeah, as far as our imaging features, they definitely do have different imaging features, and our radiologists are very experienced and very good at generally telling us whether this is an adenocarcinoma versus a neuroendocrine carcinoma. The neuroendocrine tumors are often very arterially avid and very discrete lesions versus the adenocarcinomas, which are hypoenhancing and have fuzzy borders. But there's definitely some neuroendocrine tumors that have carcinoma features that can overlap with their imaging characteristics with the adenocarcinomas. And we have been surprised several times when we've biopsied these lesions and it turned out to be neuroendocrine tumors. And yes, they are definitely treated differently. We still occasionally use for borderline or locally advanced neuroendocrine tumors, we do use neoadjuvant therapy, generally capecitabine and temozolomide. So they're treated about the same as far as their algorithm of neoadjuvant versus upfront resection, but obviously the chemotherapy is different.
Okay. Bibi, does the endoscopic ultrasound have different features for the neuroendocrine tumors than the adenocarcinomas?
Yes, they can be isoechoic or they can be hyperechoic on there, or sometimes hypoechoic. So it's variable. But when we do vascularity, they are there, as Dr. Stauffer said, they're very vascular. So that's one advantage that we can take, especially if somebody has a background of fatty pancreas or hyperechogenic pancreas, then the elastography can help sometimes, or at other times the contrast enhanced EUS can help because it will highlight, given the increased vascularity, it will highlight that lesion. So that is particularly helpful in subtle lesions.
Okay, well, great. So I guess, what are the products rich in phytates? I guess, or just just in general, just a plant-based and.
Yes, beans, lentils, legumes, they are rich in phytates.
Okay.
Nuts are rich in phytate.
Okay. Okay, so bueno, creo que si yo no veo más preguntas, si alguien querrá hacer algún comentario, está abierta, solo levanten la mano y les damos el chance de comentar si quieren, y si no, Frank, algunas palabras finales por parte tuya o por parte de tus colegas.
Gracias, Eddie, por la oportunidad de podamos participar. Estamos a las órdenes por cualquier cosa que ustedes quieran en el futuro. I'm just telling Dr. Garzuzi that we really appreciate it for the invitation for us sharing what we do here. We're more than happy to do this again in another opportunity.
Yes, thank you. Thank you.
Yes, thank you for the opportunity to present.
Thank you all very much for taking your time. I know you guys are very busy doctors and you have lots of things to do, and for taking your time to share your knowledge and your experience with us. It's really been a very nice experience for us. So thank you very much. Y finalmente, pues agradecerles a todos ustedes que nos acompañaron en la actividad. Por favor, cualquier duda que puedan tener, esto se grabó, va a estar subido al YouTube de nuestra página, y pueden accesar a esta información y otras informaciones de webinars futuros. Así que muchísimas gracias por su asistencia. Y de nuevo, Frank, Vivi, and John, thank you so much. Appreciate it. Good night.
Gracias, Eddie. Thank you guys for helping out.
Thank you.
Thanks.